All right, good evening, everyone. I'm Ryan DeVoe with the Canadian Fabry Association. Tonight, we're doing a webinar with Dr. Inbar Feigenberg, and she is a physician of clinical and metabolic genetics. She's a physician of clinical and metabolic genetics, and that's at the Hospital for Sick Children in Toronto, Ontario. And she's going to be speaking with us this evening about Fabry disease and children. So I'll turn it over to you, Dr. Feigenberg. Thank you very much.
Thank you for inviting me, and it's a pleasure to give this webinar for patients that have Fabry disease. I'm one of the metabolic physicians at the Hospital for Sick Children, and I'm the one that follow up children that have Fabry disease. In this talk, I will try to review the unique presentation of Fabry disease in children, try to emphasize what is the difference between a child that has Fabry disease and an adult with this condition. I will start with a brief introduction. I'm sure many of you know a lot about Fabry disease, and then I will start my talk specifically about children. So Fabry disease is a pan-ethnic disorder. It is characterized by the deficiency of a lysosomal enzyme called alpha-galactosidase, or in a shortcut, alpha-gal, which leads to the accumulation of a substrate or a substance called globotriazole ceramide. We also call it GB3, with the result of accumulation of glycosphingolipids in many tissues and cells in our body. The onset of symptoms can happen, and I will discuss it later in my slides, very early. However, usually the diagnosis is quite significantly delayed and happened approximately around 30 years of age. There are some atypical variants of Fabry disease that can present with isolated chronic kidney disease or cardiac condition. This will usually appear in adults and not in children, and hence I will not discuss it today. Most classic Fabry cases will result in death due to renal, cardiac, or cerebrovascular complications. The average life expectancy of an affected male with Fabry disease is 58.2 years compared with 74.7 years in the general population in the United States. And the life expectancy for female with Fabry disease is 75.4 years compared to 80 years in the adult American population. So I'm sure that you are all aware. I will speak briefly about the genetics of Fabry disease. Fabry disease is an X-linked condition, meaning that there is no father-to-son transmission. Affected father will pass the defective gene to all of their daughters, but none of their sons. It could be that a grandchild of a grandfather that have Fabry will have Fabry through his carrier mother. The prevalence for Fabry is between 40,000 to 117,000 cases, and there are more than 600 mutations that have been recorded. It is an excellent condition. However, females are not just carriers. Females are heterozygous carriers because they have usually one mutation and one working gene on the X chromosome, and they have two X chromosomes. However, the severity of the symptoms in females, in women, can be as severe as in men. Some females can be asymptomatic, and usually the presentation in women is more variable and tend to occur later in males. However, it has been established that females may develop multi-organ injury, similar to the one that is observed in men. And this is true not just for adults, but also for children. So I think this was a quick introduction of the main principle of Fabry disease. And now I would like to speak the rest of my talk. I would like to discuss the specific presentation in children. So the primary disease process starts as early as during the early fetal development. There is histopathological evidence that GB3 accumulates in kidney, liver, and nerve cells in affected male fetuses. Corneal whorling, which is the cornea vesicillata, the specific eye finding that we see in Fabry disease, was detected as early as 22 weeks in a male fetus. Children are not just small adults, and that's something that we know for a while. Children present differently and have different presentation of Fabry disease. Children mainly present with aquaparesthesia, which is the pain, angiokeratoma, the rash, heat intolerance, cornea vesicillata, it's a corneal whorling, the eye finding, and some GI symptoms. More serious complications can occur in adulthood, and I'm sure you're well aware that this disease can lead to progressive renal failure, hypertrophic cardiomyopathy, cerebrovascular disease, and reduced life expectancy. And these symptoms usually appear laterhood in adulthood and are not typical for children. The presentation in children is more non-specific, meaning that they can have significant pain, aquaparesthesia, and GI symptoms, which make the diagnosis in children even more challenging because those symptoms can be attributed to many other conditions that by far can be more prevalent than Fabry disease. And although the presentation in children is usually not life-threatening, the symptoms does affect health, quality of life, and can lead to emotional distress, depression, and anxiety. Registry data showed that the main age for symptom onset in males is 6 years and 9 years in females. So children in the first decade of life can already present with clinical features of Fabry disease. The most common presentation was the neuropathic pain, aquaparesthesia, and the mean age was 7 in boys and 9 in girls. Recurrent GI symptoms was the second most common feature, with age of male at 5 years and 9.5 years in females. Hypohidrosis, meaning sweating less than you should, and heat intolerance are also commonly reported in children. So this is just a nice diagram that presents the main differences and the main presentation in a child and in an adult. And we will see that in an adult we can be more concerned about early ischemic stroke and left ventricular hypertrophy and kidney disease. And in young patients we will see the aquaparesthesia and the GI intolerance, the hypohidrosis, the corneal whorling or cornea vesicillata, and of course the emotional stress that a young child that needs to cope with these particular symptoms might have. At this point, I think I will just describe a little bit more about each of those common symptoms that we see in children. And the first one that I will address is the most common one, which is the neuropathic pain. Aquaparesthesia is also often described in patients as chronic tingling, burning sensation in hands and feet. Pain crisis is episodic crisis of agonizing pain, usually in the distal extremities. Patient can have chronic pain with top-ups of pain crisis. This crisis can last for minutes to days, and usually decrease in severity and in frequency as the child grows older and start presenting with adult feature of Fabry disease. Aquaparesthesia was described in children as young as 2 years of age. The GI symptoms. So the GI symptoms can be nausea, vomiting, bloating, constipation, diarrhea. Boys tend to have increased severity and earlier severity and earlier presentations than girls. The symptoms present soon after the development of aquaparesthesia and can be the initial symptom of Fabry disease in up to 20% of the patients. It has been reported in quite significant amount of the pediatric Fabry population, meaning children with Fabry, and up to 60% of children up to age 10 will have GI symptoms. The earlier case report I could find in the literature was of a 3-year-old child, but I'm sure that there are other cases, and this is quite young age to present with these symptoms. Kidney disease. Kidney disease is usually later presentation, and we can see it in teenagers. Usually patients will first present with microalbuminuria, and only later at the second decade of life, 10 years and above, will actually present with some proteinuria. Renal failure has been reported as early as 16 years of age. And the reason that I wanted to discuss this is that although a kidney presentation or renal presentation is not common in young patients with Fabry disease, when we do the follow-up, we always check for kidney parameters just to make sure that there are no early signs that a child has kidney involvement, because this can happen. Renal damage is usually subclinical and identified only in renal biopsy in children. But it doesn't mean that it is not there. I think it is just not significant enough. It is built up with years and time to be more overt in adulthood and in teenagers. Cardiac presentation. Most of the cardiac presentation, as I said, present in adulthood. However, a cohort study of 22 patients with Fabry disease showed that 3 patients had progressive LVH, and that's led to the same points that I discussed when I discussed the kidney manifestation. Children usually will not present at a very young age with cardiac presentation, but it is important for us to do a close follow-up and make sure that if they do, we are able to address this in a timely manner and provide a good health for those children. Ocular or eye findings. So the cornea vesicillata is the most frequent ocular sign in both adult and pediatric Fabry population. And it occurs over 70% of male and female, including children. And this can be a very useful tool because this is quite specific to Fabry disease. So yes, cornea vesicillata can be noticed with specific medications or in other cases, but it is very rarely done. And again, it is important clue to Fabry disease, which is more useful many times compared to GI or pain that can be less specific. And sometimes we do get referrals from an ophthalmologist that wanted us to roll out the diagnosis based on this finding. Hearing loss. Hearing loss is a less common presentation in children. Children can present with tinnitus. It is the upsetting ringing in the ears that they can hear. Not so much with the unilateral hearing loss. A study checking hearing loss in children that looked at 113 audiograms done on 47 children with Fabry showed that only 6.4% of the children presented with either mild, moderate, or severe hearing loss. That was neurosensory and likely resulted from Fabry disease and not from other causes. The median age for the children that participated in this study was 12-year age, and there were children as young as 5 years of age in that study. So although there is a minority of children with Fabry disease that present with hearing loss, we usually follow up on these children with annually or biannual audiology testing just to make sure that there is no concern. And this can be a good reference for the future had they later on develop hearing loss. I'm sorry. CNS involvement in children, or cerebrovascular presentation. Cerebrovascular events are extremely uncommon in pediatric population, and the current recommendation is not to routinely monitor children with repeated MRIs. And for those of you who are who have the knowledge of what will be the follow-up for adults that have Fabry disease, you know that brain MRI is periodically done, and this is not really the case with children. Of course, if a child or more so a teenager present with concerning findings, we will order MRI as soon as possible, but we don't do it as a part of the routine workup. This is an interesting review that was done by Hopkins and his colleagues, and they discussed the management and the treatment of children with Fabry disease, and they give the United States perspective. What I did like about this study is the current slides that discuss the sign and the symptoms of Fabry disease observed in childhood. And you can see how early symptoms can present with GI problems reported as at young age of 1 year, aquaparesthesia at 2 years, the agonizing neuropathic pain crisis at 2.5 years, a heat, cold, or exercise intolerance at 3.5 years, and angiokeratoma at 4 years of age. You can also see, as discussed earlier, that the microalbuminuria present the earliest at 7 years of age, usually probably more towards the second decade of life, and pathological proteinuria usually at teenage and young adulthood. The diagnosis of Fabry disease in children is often delayed, and symptoms appear to be non-specific in this age group, and often require many years in order to identify the underlying nature of the complication. The cluster of symptoms experienced by children and adolescents with Fabry disease can negatively impact, and there are some studies about that, daily living activities and lead to depression and anxiety. The diagnosis. So the diagnosis in a pediatric population in children is not very different from the one that is done for adults. It will be a synthesis of a clinical presentation, biochemical studies like enzyme activity or GB3 in the urine or lyso-GB3, molecular testing, and if needed, pathological criteria like biopsies or a skin biopsy, or if rarely more needed, other organ biopsy. None of the features of classical Fabry disease is diagnostic by itself, and there is a need for at least 3 out of 4 criteria in order to make the diagnosis of Fabry disease. Treatment. Treatment for patients involve control of risk factors and supportive care for issues related to living with chronic diseases. Multidisciplinary team is usually required, and children are usually followed up by a metabolic geneticist or another physician that have a good knowledge of the condition. Many times they are also followed up by a pediatric cardiologist, and as needed they are referred to the pediatric pain clinic or ophthalmology clinic, audiology, and other teams that might be involved. The neuropathic pain is usually will respond to analgesia and some anticonvulsant medications. In children, we usually use as first choices, so it's either carbamazepine or gabapentin. Factors that identify to trigger acute pain should usually be avoided. So if strenuous activity will lead to pain, then we will suggest avoiding that. If overheating in a very hot weather, maybe cooling in an air condition can be helpful, etc. And the same is true for the GI symptoms. There is diet modification, like eating small meals and trying to avoid something that will cause discomfort, etc. There is also disease-specific treatment with enzyme replacement therapy or chaperone therapy that might be of benefit for patients with Fabry disease. Recombinant human alpha-galactosidase enzyme is available in two different forms, Replagal and Fabrizyme. The doses that are given are different, but both medications are equally effective, and both are approved for the use in children. Migalastat or Galaford is a chaperone treatment that in Canada approved only for adults above 18 years of age. However, there is current clinical trial available for pediatric Fabry population in United States, and children ages 12 or 17, if they are interested, can try and participate in United States. Enzyme replacement therapy. Enzyme replacement therapy was the first form of disease-specific therapy that was developed for Fabry disease. It is appropriate for all patients, regardless to the mutation status. And recent meta-analysis showed that there is some benefit for mainly cardiac and renal presentation for patients that are on enzyme replacement therapy. As I said earlier, switching between the two available ERT products will not lead to changes in changes in results, and both Replagal and Fabrizyme are good choices for patients that require enzyme replacement therapy. Enzyme replacement therapy can stabilize the nephropathy, the kidney disease, and it can stabilize the cardiomyopathy, the heart condition. It will improve diarrhea, including abdominal cramps or nausea and other GI presentations. It is yet not proven to show that it has a response to stroke or TIA, depression, hearing loss, and as it is not clear how effective the enzyme replacement therapy is in controlling aquaparesthesia. Side effect of enzyme replacement therapy is basically related to a protein infusion, which can be a fever, chill, rash, nausea, and dyspnea. And we usually start enzyme replacement therapy at the ambulatory unit at the hospital for sick children, and then we are able to closely monitor the patient for at least 12 weeks, and if they are stable and they don't present with any side effect, they can get the treatment at home, and many times it is more convenient. And if there are some infusion reactions, we are able to treat them quite effectively. A patient can also develop antibodies against the enzyme replacement therapy. A paper by Spada and his colleagues discussed the effect of enzyme replacement therapy on clinical outcome in pediatric patients with Fabry disease. This is quite a long paper, but the main conclusion from this paper is that based on, and this, what they did in this work is that they actually reviewed many papers that discuss treatment for patients and try to come with some recommendation and conclusions based on the information they gathered. And they said that based on the published literature, the use of enzyme replacement therapy in children with Fabry disease can significantly clear the GB3 accumulation, ameliorate the early symptoms of Fabry disease, and improve quality of life. Treatment with enzyme replacement therapy in children with Fabry disease may be important to further prevent disease progression and overt organ damage. And in this, by saying that, this is not very different from trying to treat in a timely manner adult with Fabry disease. We know that if the disease had progressed to a level that there is significant damage, sometimes the enzyme replacement therapy will not be as effective as it is if we start treatment earlier. The use of enzyme replacement therapy in children is well tolerated. However, due to the high cost of this treatment, the timing of when to start enzyme replacement therapy continue to be guided predominantly by country-specific treatment criteria. And there are specific Canadian criteria to the treatment of adult and pediatric population with Fabry disease, which can be quite different than the ones that are in the United States or in Europe or in any other countries. Enzyme enhancement therapy or chaperone therapy. I will be very brief discussing this option because it is not clinically available. However, in many cases, when compared to normal, the disease is caused by misfolding of an enzyme as a consequence of a missense mutation. Under normal conditions, this misfolded enzyme will be recognized in the cell and will be led to degradation systems. However, in the presence of pharmacological chaperone, there is stabilization of the misfolded enzyme, which allows it to safely pass into the lysosome and work in the lysosome, albeit less effectively. The principle of the therapy has found favor potential treatment for a specific patient, and this type of treatment is mutation related. So not like ERT, it is not that every patient can get this treatment. There is a list of mutations that this treatment will be effective for, and there are others that likely this is not a good treatment for them. The recommended follow-up for a pediatric population with Fabry disease. Oh, sorry. So usually, so this is again taken from the paper by Hopkins et al., and it is quite similar that discuss what are the guidelines of treatment in the United States, and it is quite similar to what we do here at SickKids. So we usually see patients and do physical exam and get good history twice a year. If it's a very young child or asymptomatic, we can see them once a year. We will do kidney functions. We will do some urine testing, looking for early microalbumin in the urine or protein. So there are a few studies in the urine that we will collect, and we do it every time the patient will come. Patients are followed up usually by a pediatric cardiologist, and they will have echo and ECG as per protocol, usually every 1 year or 2 years, depending on what their initial presentation and age is. If a cardiac MRI is needed, it is usually something that will be decided by the pediatric cardiologist. We don't do brain MRI on a routine basis. However, usually before the child graduates from SickKids. And at SickKids, we see children and teenagers up to the age of 18. So around the age of 16, 17, before they graduate, we will do one MRI, mostly to have a baseline for these patients that might serve them later on when they are adults. In regards to the neuropathic pain, we work closely with the pain clinic and we refer patients as needed. And as I said, mostly patient will be treated either by gabapentin or carbamazepine. And we definitely assess and ask about pain every time we see a patient in our clinic. And the same is true for the GI presentation. We will do a good physical exam, good neurological exam, and we will also do some blood work screening for possible comorbidities, looking at cholesterol, glucose, electrolyte, kidney functions, etc. There is an important part for genetic counseling once a patient with Fabry disease diagnosed, and it is being said and reported that when a first family member is diagnosed with Fabry disease, there are average of 5 additional family members that actually have this condition. So when we see a patient for the first time or get results of molecular and disclose a diagnosis, we usually work quite closely with the metabolic genetics genetic counselor within our clinic that can give genetic consultation for the families in regards to risk factors for other family members. Um, um, okay, so in summary, today I have discussed the specific presentation of Fabry disease in children. We have discussed that children are not just small adults, and they have a presentation that is quite different than the ones that we see later on in adulthood. That many of the things that children present with are non-specific, and many times the diagnosis is delayed. This is in paradox with our knowledge that early diagnoses have implication for early follow-up treatment and better outcomes in children. And the role of a metabolic pediatrician is definitely to raise awareness and do some education for presentation of rare diseases in general, and Fabry especially in pediatric population. Because family physicians or pediatricians will not think about Fabry when a child presents with the initial presentation unless there is a family history of this condition. So I think I finished my slides and I will be happy to take any questions.
All right, thank you very much for doing the presentation with us. Just while we wait for questions to come in, I really appreciate you taking your time and doing this with our members. If anyone has any questions, you can type them in the chat window, and then we can read them. If you wanted to send any directly to me, I can read them. I can read them on the stream. If you didn't want to type it in the general chat, just change it, instead of to everyone, change it to send it to Ryan DeVoe. Perfect. So I'm not sure if you're able to see the chat window, Dr.
No.
At the bottom, there's a button called chat.
Should I leave the presentation?
You can stop sharing if you like.
Oh, okay, how do I?
At the bottom, if you click on the share button, you can stop the sharing. At the very bottom of your screen, if you move your mouse down, it'll pop up the bar. Or it should be there.
I'm not.
Oh, actually, there you go. I got it for you.
Oh, thank you.
No problem. So now you should be able to see the chat button. Down. Right.
Yes, we do see the chat button. Yep.
All right, perfect.
So, okay. What are the various specialists that might be for the diagnosis? Okay, so usually what we do in the hospital, can you see me? Okay.
Yes.
So what we usually do at our clinic is that we refer patients to see the pediatric cardiologist,